So underdiagnosing is the worst error we commit. So in other words, we tell patients they're clear when in fact they're not. And to correct that now is pretty straightforward. You've just got to use the best test, and we now know that that's imaging in the form of MRI. If you use MRI, you'll find nearly all clinically significant cancers. In the PROMISE study, we missed 17 clinically significant prostate cancers, whereas TRUST biopsy missed 119. Of those 17 clinically significant cancers, none were bad ones. And so if your MRI is negative, we can rule out with 100% precision any truly significant prostate cancer, in other words, the high Gleason grade cancers. So I think underdiagnosis we've now kind of sorted. Overdiagnosis is a lot more difficult to kind of understand. And this is telling patients that they have a cancer diagnosis, but those individuals are not destined to die of that disease, and therefore the label of cancer doesn't serve them any function, and any treatment that we give to them can't benefit them because they're not destined to die of their prostate cancer, and so treatment can only incur harm and cost. Now, all diagnostic strategies incorporate some degree of overdiagnosis because we're not perfect and our tests aren't perfect, and that gives us the kind of wriggle room to try and identify the disease that we want to. Prostate cancer's been interesting in that there is nowhere else in medicine where we have such a high degree of overdiagnosis. Breast cancer has a fairly high degree, but nothing compared to the prostate. The way to avoid overdiagnosis is to try and limit the number of men that you biopsy, and also try and change the way that you biopsy those men that you do. Historically, the approach has been to use biomarkers to try and avoid unnecessary biopsies, in other words, biopsying men that don't have clinically significant prostate cancer. These days, I think imaging is probably going to offer us our best hope, in that a positive MRI is associated with volume and grade. So increased volume and increased grade, which are interestingly the two things that are associated with a prostate cancer death. MRI is not good at seeing tiny little bits of microfocal 3+3, which I have a 30% chance of having today, and most men will die with, when they do eventually die of whatever cause. So MRI is very good at overlooking the disease that we're not interested in, but almost perfect at identifying the disease that we're seeking to rule out.